all of you. I'm happy to be talking on hypoplastic left heart syndrome, and I'm here in Mumbai at Fortis. Please let me know if the audio or video is not clear. So why is HLHS so important to know about? Let's just briefly talk about that. Well, it is a small percentage of all congenital heart defects, less than 4% of all kinds of CHDs. But if you look at the number of neonates who would expire from HLHS, then there's a significant proportion. Now you have statistics from United States where they say their neonatal cardiac deaths, around 30 to 40% of them are due to HLHS. So suddenly it's important. Knowing more about HLHS, its variants, has important implications on the management as well. When would you repair? What kind of plan would you do? What are the chances of sudden death in that particular variant? What are the long-term morbidity mortality numbers? This somewhere here maybe. Okay, so that's a pathologic specimen of the hypoplastic left heart. You see a prominent pulmonary artery, you see a huge ductus, and you see the ductus continuing as the descending aorta. On the other hand, the ascending aorta is tiny, and you see these branches given off which are normal size, which is always the case. A small pretest quiz that all of us will take, answering with simple yes and no by your own self. So are all HLHS duct dependent lesions? We can come back to this slide once we are done. Think about it. Are all of them duct dependent? Do all of them have severe LV hypoplasia? HLHS isn't associated with any genetic syndromes, yes or no? Is that a true statement or a false statement? What does epigenetics mean? The variant of HLHS with aortic atresia and mitral atresia is associated with coronary fistulae, yes or no? Role for BAS in HLHS, yes or no? And maternal hyperoxygenation, has anyone heard of that? And it's used in CHD HLHS. So things for us to think about. In the next 45 minutes or so, I would like all of you all to be able to be comfortable differentiating between left heart, hypoplastic left heart syndrome versus hypoplastic left heart complex. Be familiar with the no flow, no growth theory. Have an idea of the etiology of HLHS with a little detailed discussion on genetics. We'll talk a bit about pathology of each component of HLHS, clinical presentation, a few slides, and we'll end with fetal diagnosis of this disease. I'm going to actually have my take-home message put right here, so you will know what this whole talk is about. What's the focus? Does anyone recognize this paragraph? I'm going to read it out aloud. We stand on the shoulders of many women and men, many iconoclasts who defied the norm and set the course for development of our specialty, which is pediatric cardiology. They were often criticized but kept on going. Without their contributions, we would not be here, and a huge debt of gratitude is due to each. This author writes. Now this is something addressed to trainees. You who are fellows in pediatric cardiology are challenged to pick up the baton from now on. Find the genetic causes for CHD, find ways to treat and prevent the causes. Put us out of business. In the meantime, improve diagnostic and therapeutic techniques and apply them with compassion. Anyone recognizes where this is taken from? I may not be able to hear you. Actually, there's something wrong at my end, but you could type a reply. So this is actually from our pediatric cardiology textbook, the history of pediatric cardiology chapter, which I hope all of you have read, and if not, please read. This is the last paragraph. So you see the emphasis on genetics, which is what we will be doing here as well. Moving on to the definition of HLHS. It is obviously anatomy and hence echo-based definition. If not echo based, you've got pathologists who will tell you exactly what it is and what it isn't. The persons who do things about it, the surgeons, have the Society of Thoracic Surgeons Congenital Heart Surgery Nomenclature and Database project. They've been very stringent about trying to classify things properly, and periodically they've been coming up with names and terms that we should use to describe things. Unfortunately, it has not caught on, but I absolutely appreciate what they're trying to do, and if we were all to follow it, life would be much more easier. Simple example is VSD types. We all know the confusion surrounding names of VSDs, how all of us have our terms that we use and others don't. Subarterial, subpulmonic, doubly committed. There are so many names for a single kind of VSD. So as far as hypoplastic left heart syndrome, back in 2000 in the Annals of Thoracic Surgery, this Congenital Heart Surgeon Society got together to define things very, very properly. This has implications also on billing. When you want to obviously give different bills for different kinds of hypoplastic left heart syndrome. So let's look at the classical HLHS. This is a spectrum of cardiac malformations characterized by a severe underdevelopment of the left heart aorta complex. So far so good. Now, as far as the aortic and the mitral valves, there is either stenosis or atresia, so that is central, stenosis or atresia, or severe LV hypoplasia, and hypoplasia of the ascending aorta and the arch. It would follow that we need retrograde perfusion of the ascending aorta. So aortic atresia or stenosis, mitral atresia or stenosis, small LV, small ascending aorta, and therefore the ductus retrogradely perfusing the ascending aorta, from where coronaries would arise and would obviously be vital. Let's hope this runs. Right. So here's a suprasternal view of the aorta. You see the blue flow, which is normal. I hope also able to appreciate that there's a red flow, that means blood coming up to the cranial end of the photo, which is showing retrograde perfusion. So if you see something like this, along with the things I mentioned before about the aortic valve, the mitral valve, the LV, then you're looking at a classical left heart syndrome, hypoplastic left heart syndrome. Now, what is hypoplastic left heart complex? Well, we're talking about a subset of the HLHS, which is better off than the classical HLHS. There's hypoplasia of the aortic and mitral valves without valve stenosis or atresia. There is LV hypoplasia, LVOT hypoplasia, and ascending aortic and arch hypoplasia. Basically, degrees of hypoplasia of the valves, the LV, the LVOT, and the arch. But there is no aortic and mitral valve stenosis or atresia. What there is annular hypoplasia. The valve annuli measure out small. So that would be, you could, in such a patient where the annuli are small, no stenosis, no atresia of the aortic or mitral valves, you could label the complex as hypoplastic left heart complex, not a classical HLHS. Let's move on to now what is the pathogenesis, how does this happen? And unlike TGA or TAPVC, where you have specific things happening very early on during heart formation, you've got a wrong vascular connection, or in both cases actually. For HLHS, it isn't so simple. And the most propagated theory is the no flow, no growth theory, where it says you have reduced flow in fetal life, and because of that, you've got something that can progress on to hypoplastic left heart syndrome. Now, this might be reduced, this might be, mitral and aortic valves being developed small to begin with. So yes, that's the primary problem. But because that's causing reduced, that has reduced flow, let's say mitral valve is small or stenosed, Then you have the LV being small, and hence you have the LVOT being small, and the ascending aorta and the coarctation follows. Similarly, if the patent foramen ovale is restricted, you have less blood seen by the left atrium. Therefore, mitral valve is small, and subsequently to that, you have left heart hypoplasia. This is the no flow, no grow theory. If you dig a bit deeper into finding out why this is, what is the exact etiology of HLHS, it's pretty multifactorial. Epigenetics. Epigenetics to study of how phenotype is altered even though the genotype is not altered. So you've got this gene sequence which is normal, but it gets altered. So the phenotype gets altered, and this gene sequence, there's some post modification which may happen by DNA methylation, histone modification, or other certain things. But I think DNA methylation is a very common form of epigenetic modifications. Now, how does DNA methylation get impacted to alter the phenotype? It could be things like environmental pollution, infections, nutrients, etc. Rubella, is associated with multiple defects. There's also flu during the first trimester. There's data to show that such women with flu in the first trimester are twice as likely to give birth to a baby with CHT than compared to the general population. Maternal beta hemolytic strep pharyngeal infection in the first trimester has been implicated in HLHS. And if this is more likely in certain seasons, and that's what some studies have shown, that HLHS also has a seasonal variation in occurrence. Drugs have been implicated. Benzodiazepines, lithium, isoretinoin, and topical retinoids for a wide variety of CHTs, not necessarily just HLHS. And ibuprofen in the first trimester also twice as likely to have a baby with CHT. Organic solvents, so you have nail paint, you have glue, a lot of other things, things that we use in beauty salons and carpentry, manufacturers of inks, and some of these professions are female dominated, so you can imagine how females would be much more exposed to such things, and this would become important if they're pregnant. There is a study out in 2014, maternal lead exposure and risk of fetal CHT. This